So I wanted, on behalf of all of us here at the Mental Health Association, I want to thank you for joining us. You know, we are saddened that we can't be together at Duchess Daughters for a lovely breakfast, but we're excited about our speaker today and what she has to share, what we think is a very relevant topic. So just a few housekeeping notes. I'm going to mute everyone during her presentation. We will be monitoring the chat. So if you have any questions at all, please feel free to put them in the chat and we will make sure we have time for questions and answers at the end. If there's anything particular about the Mental Health Association as well that you'd like to ask, we have Shannon on with us as well as some of our senior staff members. So please feel free to put questions in the chat. And with that, I will introduce our CEO, Shannon Alshire, to begin our presentation. Thank you.
Thanks, Rebecca. Good morning to everyone and welcome to the Mental Health Association of Frederick County's 35th annual legislative breakfast. Like so much of life in 2020, this event promises to be like no other. COVID-19 has changed the way that we live, work, and play, all while focusing a laser-like light on the importance of mental health. So at the Mental Health Association, we work to build a strong foundation of emotional wellness for the whole community. And we do that by preparing resilient children, securing vulnerable families, and standing with people to face crises together. Like all other businesses and nonprofits, we've changed the way that we work over the past 8 months. But what hasn't changed is the fact that we are still here 24 hours a day, 7 days a week, with a caring, supportive voice in moments of crisis, resources and information that show the way forward, and personalized, sustained assistance to everyone in need. Each one of our 13 programs has found ways to continue supporting our community and its currently evolving needs. So I'd like to thank all of you for attending yet one more virtual event. I know that we're all a bit weary of screens, so it means a lot that you took time out of your day to be here with us today. I'd also like to extend a special thank you to the legislators who are here today. We have Ada Khan, who is representing Congressman Trone's office. We have Council President MC Keegan Ayer. We have Delegate Ken Kerr, Nan Mann, who is representing Senator Christopher Van Hollen's office, Frederick City Mayor Michael O'Connor, Delegate Jesse Pippy, Alderman Dr. Derek Shackelford, Kimberly Shiloh, who is representing Delegate Benjamin Brooks, Alderman Roger Wilson, Congressman Jamie Raskin, Councilmember Jessica Fitzwater, and Joy Schaefer, who is representing County Executive Gardner's office. If I've missed anybody who joined late, please send me a chat and I will add you at the end of the presentation. So this pandemic has also spotlighted disparities in our nation and in our healthcare system. And that's why I'm so pleased to introduce our speaker today. Dr. Jocelyn Swanson-Apollon has over 30 years of general medicine experience. She received a Master's of Public Health from the Bloomberg Johns Hopkins School of Public Health and her MD from Tufts University School of Medicine. Currently, she is the owner and CEO of UNI Urgent Care Centers, founded in 2008, with multiple locations in Maryland, including Frederick. She is on the front line of healthcare with a front row seat to the COVID-19 pandemic and its detrimental impact on our already fragile healthcare system. Previously, she has served as the Chief Medical Officer of the Emergency Department and Outpatient Clinic for the U.S. Army Medical Services and Medical Director for the Department of Defense, where she supervised physicians, physician's assistants, nurses, and active military medics. In addition, Dr. Apollon was clinical research physician at Parexel International in Baltimore, where she was responsible for executing all appropriate pharmaceutical investigator responsibilities. Dr. Apollon has also worked for NBC New York as a medical correspondent, covering healthcare issues, addressing community and global medical concerns. It's an impressive resume, and I'm so glad that you're here with us today. I encourage everyone to join me in welcoming Dr. Jocelyn-Apollon, who will be presenting the Healthcare Puzzle, Medical Care Delivery, Healthcare Access, Equity, Mental Health, and the COVID-19 Impact. Take it away.
Thank you very much. I will share my screen now with some help. Let's see. One minute.
Okay, we're seeing it.
Are you? Good.
Yes.
All right. Good morning. I am Dr. Jocelyn Swanson-Apollon, and I am, let me see, how do I get this away from here? Well, I guess I can't really. I want to talk a little bit about healthcare disparities, specifically about health access, health equity, mental health, and what's really on the table has brought everything to light, and as well as the holes in healthcare, the COVID-19 pandemic, which affects us all. Healthcare disparities. If you put a puzzle together, you know that you can't finish it because you have so many missing pieces, then you have healthcare disparities right there. It's in your face. It's because there's so many different aspects of healthcare that need to be evaluated. And you look at social needs, you look at medical needs, you look at social norms, communities, and how people feel about healthcare and whether or not they are comfortable in what they do. And you also look at several other things. Let's talk a little bit about healthcare disparities right now. So if you look at healthcare, let's first talk about the puzzle itself. What exactly is a puzzle? By definition, it's a problem. And and as a verb, it simply means to challenge mentally. And are we challenged? Indeed, we are. We are challenged not only because of lack of healthcare in some areas or differences in the healthcare in some areas, but also we have the COVID-19 on top of all of those things. So let's start with medical access barriers. Some of the barriers are structural. Some people don't have transportation in their communities. They don't have buses, they don't have cars, and even if they did, they can't get out of their community or the money to get out of their communities. What about providers? Some communities don't even have the number of providers that are needed for the population in those communities. So that's another aspect altogether, or the appointment availability for those providers. Financial resources, health insurance plans. Now, most people think that health insurance plans, if you have health insurance, suddenly you have a gold card. But in fact, health insurance plans also can be limiting. Some insurances will cover some things and others won't. They also some insurances limit the provider choice. So you like to go to a certain provider or a certain specialist, but the insurance limits you to go there. So that's right at the beginning. We see patients all the time, and we do write a prescription, evaluate them, only to find out or get a phone call from the pharmacy or from them saying they can't afford that that medication. Well, the medication should be covered by your insurance when it's not, because there's a list, and we actually receive a list from the insurance companies almost every 6 months saying what they're covered and what they're not, what's on their list and what's not. And it can be mind-boggling. So you always have to weave through all of those depending on the insurance that the person has. And also the insurance is going up every year. The deductibles are going up, the cost is going up, and people are dropping off the rolls. So you have a lack of insurance at that point. We deal with language barriers as well. When it comes to language barriers, of course, people are coming from other countries, or they've been here and they can't, nobody can understand them unless they bring their own someone to translate for them. Let's look at age. I call it the 80-20 rule, which it actually is. Medicare pays for 80% of your insurance. The 20% is covered by the patient themselves. So if you cannot afford, if you're on a fixed income, you cannot afford to pay that 20%. So what happens? They avoid coming to the doctor. They avoid getting there, filling their medications. And there is no preventive health care. They lack it because even though it exists, if you have to pay 20% or more on your deductible is high, you tend not to come to healthcare or seek healthcare until you're actually sick. So, you know, preventive care is so much cheaper than trying to treat somebody for something that's beyond diabetes, heart disease. So if you try to prevent these things and some of the side effects and the sequelae of these things, then it just makes more sense. But again, it's the bottom line, and it's the healthcare issue, and it's healthcare insurance. And I have something called Medigap. Now, when it comes to a Medigap, Medigroups, I'm talking about, this is another barrier. Medigroups are ethnic minorities, lesbian, gay, transgender, sometimes women, children, elderly, disabled, or lower socioeconomic backgrounds. Sometimes these groups fall through the cracks. One, because they're not comfortable in certain environments. Sometimes they're made to feel uncomfortable by the people seeing them coming into an office, or trying to figure out, okay, so your name on your driver's license is this, but you're saying that you are now a she, but you were born a he, so what do you want us to call you? That can be quite uncomfortable. And so we have changed how we do things. So it's not just what gender were you born, what gender do you identify with, and what name do you identify with? Now, please note that we still have to use their born given name unless they changed it legally, but we can call them whatever they want to be called. And it is a problem, and they feel uncomfortable, and it's unfortunate. And it's a different, whole separate aspect dealing with these groups. And then you have people. You have people who just have personal choices, based on personal choices. They have certain personalities. Some of them are type A personalities. They're gonna go and get what they need to get no matter what. And they tend to seek out care and very good at personal and preventive health care. And then you have those sort of let it be. My mother, my father never went to the doctor, and so why should I? You know, they're going to give you some medicine that's going to hurt you, then help you. You have cultural norms, and then you have social needs. Let's talk a little bit about that. Social needs. When people have to make a choice between their needs, their food, basic food, shelter, safety, and financial resources, versus they might have elevated blood pressure, they might have diabetes. People come into the office with saying that I'm having a problem with my sight. I can't see, it's getting worse. And it's getting worse before they come in, totally. Even though they've noticed it 5 or 6 months ago, the fact that it's getting worse, they come in and you look, you think, okay, this looks more like a diabetic change. And so you test them in the office only to find out they have diabetes. Of course, some of them will fight you, say, I've never been told I had diabetes. I don't have diabetes. It doesn't run in my family. Well, you do. And by the way, you're obese. And by the way, you don't exercise. But it's all in how you say it and what you say to try to grab them in give them some education about how diabetes is type 2 diabetes is developed, how the impact it has on your heart, the impact it has on your sight, the impact it has throughout your body. We've seen people come in with foot sores that just won't heal. And when they take off their shoe and you see it and you try to figure out how is it that this person has walked around for months, even years. I've seen something with years. It's, oh, I just keep changing it, but it's getting bigger. And you find, and then you would be surprised at what people, maybe you won't, be surprised at what people deal with on a daily basis. And then they come to the physician. And then you see, because because things, the layers are pulled back and they unfold. And you can't hide from that. And this is when you get to address it. But these things, most of these things could have been prevented. People come in with kidney disease. They come in with, they think they have a UTI, but you're looking at spilling not just protein. There's glucose. We look at the urine for several different things, and then you say we get some blood tests. Let's check your kidney function. Find out their kidney function is decreasing, and they've never had it checked ever. Nobody's ever looked. People just gives them antibiotics and keep moving. And then these people end up on dialysis or worse. So prostate cancer, of course, in the minority community, many men, actually men, period, but African-American men strictly don't want to have their prostate checked. You can have the PSA, but so you sort of get the prostate cancer, it's already developed. By the time they have the problems with, they can't urinate, or they have dribbling, or they have a full bladder, but they can't get it out. And that's when they figure, oh, maybe I have a urinary tract infection. Well, no, you don't usually see urinary tract infections in men. You can get a few, but it's rare. So you're looking for things like urethritis and checking the prostate. So these are things that we deal with every day. People come in with chest pain. They figure they're stressed, they're isolated, they didn't get their medication. I saw a young lady the other day who had hypertension and has been off her meds for a year. And you want to know, why didn't you take your meds? She couldn't afford them. So then I think to myself, I can write a prescription today for you. I can do a workup, only that you're not going to fill it if you don't have the money to fill it. So then you find other ways. There are all kinds of little cards, cover my meds, this and that offer a different way to get medications. Even if you have health insurance, you can get it cheaper by saying, don't use your health insurance to get this medication. Give them the card, and you can get it for, look around, you can get it for $10 as opposed to $50 with your insurance. Why? Because insurances contract with pharmaceutical companies for certain prices. So no matter what you do, that's your price. But you can go outside of that and use a different aspect of it. So educating people about ways around to afford their medication so that they don't develop or get worse. And let's talk about COVID-19 testing. COVID-19 testing, initially when we started, it was only test those people with symptoms. And they have to have these specific symptoms: fever, cough, shortness of breath, only to find out later that most people don't have any symptoms at all. And most people don't have fever. We spend a lot of time taking temperatures to enter the office, but most people don't have a temperature. So, okay, that's done. And people are doing it at the offices, they're doing it everywhere. But no, most people don't have a temperature. Most people don't have a cough. So the bottom line is that initially our hands were tied as physicians to test people, even though you said this person probably has it, but they don't meet this criteria. So Department of Health says we can't test this person because there's limited tests. We understood that. And then they expanded the diagnosis and expanded the testing possibilities And then they left it into our hands to test anybody and everybody that wants it, that wants a test, only to find out that the numbers were off the chain, and they continue to increase. And you wonder why it's spreading so much, because some people have just gotten lax, and other people refuse to get testing. People have political reasons behind it. It doesn't exist. Well, it does. You know, I said, we know this is not a ghost disease. It can be a death disease. And the more you know about it, the better. Forget politics. Just look at the facts. It is a disease. It's a pandemic globally. And so we have to address those things. And then preventive services. It's very difficult to offer, or for someone to even begin to look at preventive services anywhere when they are afraid of getting COVID-19, those that believe that it exists. When you are barely making it, when you have issues like food, shelter, and safety, and financial issues because of job loss or unemployment or anything like that. So if you don't have a sense of just basic social needs being met, then the last thing you're going to do is worry about your hypertension, diabetes, heart disease, kidney disease, or anything else at that point. So people make choices, and a lot of times it's a wrong one, but you can't fault people for making sure their social needs are met. Let's talk about health equity. So when you say health equity, what do I mean by that? Health equity has to do with allowing or helping people to reach their highest level of health, and communities reach their highest level of health. If you look across the board, and you can actually pick out certain communities that have longevity, they have health, they have a decrease, they have less hypertension, diabetes, they have and they live longer, and their highest level of health in their community just puts everybody else to shame. Why? Because they are more engaged in that community. They address the issues, and they have implemented health empowerment zones. What do we have to do as healthcare providers is to make sure that we engage the communities, to look at the communities and actually admit or acknowledge that there is a problem, that identify those problems or issues, because it may not be a problem for people in those communities because that's their norm, but identify the issues, address them, and help from within implement health empowerment zones to mitigate these things. And we have to lead with presence, meaning we can't just throw money at communities or individuals. It said, let's give them insurance, the ACA, let's give everybody insurance. Well, you give them insurance, but they don't go to the doctor. You give them insurance, but they don't fill their medications. You give them insurance, but they're limited on who they can see, how many services they can have, and what medications they can have. So I've fought many times with insurance companies on medications because some medications work and some of them don't. Even fighting for a generic one with some of the insurance companies. And it's a crazy set of, it can be a crazy situation having to fight for medication for the patient. And after a while, they just give up. Let's talk about mental health. Sometimes you just have to throw all the pieces on the table. Because in those pieces, you've got anxiety, you've got fear, you've got isolation, and we ask people to quarantine, to self-quarantine. If you have some person that's already feeling isolated, already has fear and anxiety, and you ask them to quarantine, it's almost like a death sentence. It's unemployment needs, it's the basic needs, it's distrust in the system. And sometimes for good reason, sometimes not so much. And this brain fogginess, you hear about brain fogginess and people that have had COVID, they tend just to not totally get back to normal. It takes a long while, and this study is still going on, trying to see what is happening, what is truly happening. But there are some people that had brain fogginess before COVID ever happened, and we haven't addressed it. There are conspiracy theories. There are people coming in with racing thoughts. We have, we send people to, we see people all day, every day in our urgent care center and centers. And a lot of what's underlying is a mental health issue. So they come in for ear infection, but they also say, oh, by the way, I can't concentrate. Sometimes my thoughts just take over and I'm having a hard time concentrating. They come in with a sore throat, strep or not. Oh, and by the way, my heart just pounds sometimes. And it's like it's coming out of my chest. So I have panic attacks. You have, I've had a patient come in and wanted to know, I literally just came and said, my wife sent me. I said, your wife sent you? Why? Is there something going on at home? And he said, well, she thinks I need some medication. So I came to get some medication so we're going to a party later tonight. I said, so what kind of medication does she think you need? And sometimes you have to just start where they are. And said, well, I don't know. She just said, get some medication. So, I start talking to this person and they said, well, you have any chest pain? You have any visual changes? You have abdominal pain? You have nausea, vomiting, diarrhea, fever, chills? We go through the whole process, head to toe. And the answers are no. Then I say, well, are you able to sleep? He said, no, I'm not sleeping very well. Do you have, are you hearing voices? Oh, absolutely not. Okay. Well, do you feel that sometimes inanimate objects are talking to you? And he looked up, disturbed, and he said, well, sometimes my radio is saying things. Which radio? The one in my car. So if you don't ask the questions and delve a little deeper, you would think that maybe it's just something going on at home and she needs a break. Maybe we get those two. But in this case, this person was having auditory hallucinations. So if I just stop with, are you hearing voices of people telling you things that you don't want to do and nobody else hears, and stop there, I would have never gotten to the point that it's not a person talking to him. It's an inanimate object talking to him. So you have to be able to, when I went to school, when I went to med school at Tufts in Boston, the training was different than it is today with many of the newer providers. And I know that I see it. It's treating the whole person, community service, community healthcare. And so I'm literally mirroring what I've learned over the years. And so these things have to be addressed, and it can't be a 15-minute in and out. Sometimes it takes a little bit longer to talk to people, to fill out what's going on and why. Obesity in itself is not simply they eat too much. Sometimes they eat to soothe. Sometimes they eat because that's all they have. And that's all they have that they can control. So sometimes you have to work and look at those things. And look at the basic needs, look at the social needs, and look what's behind the fence. at this stage of the game, I think a whole lot of people are having racing thoughts because of fear and anxiety over COVID. And it's bringing out, it's lifting the veil for many things that we are seeing. So where do we start? What do we do? Well, if you look at a puzzle, which pretty much life can be, you look at, some people are edge starters, some people are middle starters. An edge starter tends to encapsulate a community. You going from the outside in, not getting a full picture of what's really happening in the community, but you're just looking at the outside in. And then the plan is to work your way inward. And then you have the middle starters. They just dive right in, acknowledge what's going on right from the start, and work their way out to build a more health-centered community. Which way is the best way? I don't know. It depends on the personalities, it depends on the community itself, and it depends on the needs of the community. Either way, you have to start. So healthcare is multifaceted. You have the social norms, you have communities, you have professionals, you have specific needs, you have IT, you have collaborations. It's a mixture, and you have multiple personalities. So everything plays a role in healthcare. So it's not a one size fits all. So here we have a beautiful, multicolored, multifaceted, well put together puzzle. But what's lurking in the background is what we truly have. A lot of missing pieces. And we have to address those things. Because if you don't, and if we don't, and it's us, not of them, if we don't, it's going to be more of that than what we really want in the front. And those holes are slowly cracking more and more. So let's talk about what's really happening. Primary care, and we're focused on primary care quite a bit because we figure if you have a primary care provider, you won't be caught, without being treated, not being diagnosed, without the preventive care portion of it. But primary care is not bouncing back. We lost a lot of primary care physicians, a lot of primary care providers, which has led to even less access. People are afraid, and providers are afraid to have patients in their office. And many of them have closed and are not coming back because they don't see a way out. So that leads to less access. You have increased job loss in communities, and company closures also leads to less access for care. Increased hospitalizations, increased death rates due to COVID, suicide rates, an exodus of medical providers. The 211 calls are up 425% than the previous year. If you look at April to June, just April to June. And the 211 call, so if people call referral lines or food or rental assistance and mental health access. The basic social needs are not being met. Opiate substance abuse and addiction is up. Domestic violence, we ask people to self-quarantine, to isolate. If you have a spouse or a partner who is abusive, and now you have to self-isolate with them, what do you think is happening? And then I have something called the poo effect. I call it that one because, you know, they're testing for public housing, that is. They're testing, they're doing wastewater testing. So that's to help detect and respond to COVID-19 outbreaks. I think it's ingenious. You pick it up because it's coming through excretions from the body. But here's the thing. You're catching it after you've already had the outbreak. So there's no prevention there. The prevention is to test and not have the outbreak. But this is what we have. You have to start somewhere. And this is one of the external starts. So it's interesting that I think that if you, in addition to this, that you increase the testing of those people, of those in the public housing, give them access to care, that you should not have the uptick in the wastewater testing. You should not find outbreaks in that if you're preventing the outbreaks, if you're giving them the mask that they need. So just a view. And so let's talk about some solutions and some thoughts. First, acknowledging that there is a crisis, a healthcare crisis, and within that, there's a COVID global crisis. And to tackle it full head on, to make sure that it doesn't stop us in our tracks to the point of no one can move forward. Loss of jobs, loss of businesses, loss of healthcare. So then where are we then? We have to engage in meaningful conversation with community leaders, and that means financial, social needs, as well as jobs. And healthcare access. So health insurance parable is unevenly yoked. Health insurance is not health insurance, it's not health insurance. It's different for different people, depending on what kind of insurance you have. Even the people that have jobs, the hours is for the company is going up 9% this year. It's crazy. The deductibles are going up. So what are you really getting? You have to wonder. What are you really getting for what your bang for the buck when it comes to health insurance? We have to stabilize it some kind of way. The insurance companies are making a lot of money, but they increase the rates, and plus people are pretty much paying as they go, their deductibles and their copays, but they're getting less and less. So something has to happen. That has to be looked at. Am I purporting socialized medicine? No, because that's not going to work either. But it has to be, something else has to happen. We have to look at and work those things out. Because right now it's a pay to play, and the more you play, the more you pay. And if you have no money to do that, what happens? And to look at, focus more on prevention. It's so much cheaper to prevent than to treat. And it actually decreases the death rate. It decreases the number of people hospitalized if you try to, so across the board, it helps to decrease those things. I don't have any more slides. I would like to simply say, where am I? Let's talk more now. We can talk about some of the views that, if I can find you guys again. Here you go. There you are. Hi. So you have any questions about anything? You have any? Can you hear me?
Yes.
Yes, we can hear you.
All right.
If you stop screen sharing, it might be easier for everyone to see each other.
Okay, all right. There we go.
Perfect.
So I'm open for questions, thoughts.
Okay. Dr. Apollon, this is Alita Harris. Thank you so much for your presentation. I have a question for you. Can you hear me?
Yeah.
Okay. I have a question regarding insurance versus private pay. I'm currently a nurse. I work at an insurance company with Johns Hopkins, and I know a lot of providers, especially in behavioral health, are leaning more towards private pay because of the issues with credentialing and getting insurance reimbursement. Do you feel that there is a trend, or what are your thoughts on insurance versus private pay?
Well, it depends on the insurance, of course, and I'm quite aware of how Johns Hopkins pays or doesn't pay. But anyway, don't get me started. But anyway, so you see somebody for 2 hours or an hour, they want to give you $20. It's like you may want to have the patient pay. So I mean, they're both ways. I mean, they're both things, because it has to be a win-win situation. You can't. I think a lot of it has to do with we can't have people paying at this point because people don't have the money, and so what you do is end up decreasing the number of people seeking the help because they can't afford the help. So there might be a long-term way of having insurance pay, but have it so that they don't set pay, so that they don't come back and go, I know you said you did this, but we're only going to pay you that, which is what most insurances do. We charge a certain amount within the contract price, but even sometimes they'll come back and go, well, no, we're not going to pay for this, this, and that. And so they give you just a piece of it. So after a while, it's frustrating, which is why a lot of docs are saying they're done. They can't constantly be chasing and fighting with the insurance companies because they have the control. Or you have patients upset. Well, why did you? Well, I got a bill and blah, blah. So well, you need to check with your insurance company. This is a contract you signed with them, not us. We don't control that. They control that. So it's really there has to be a way to sit down with insurance companies and with the people out in the field that are actually doing the work to come some kind of consensus, so that people don't feel that they're working for nothing. And the patients don't feel that they're not getting everything they need, or they have to come out of their pockets. I think in a better time, it would be fine for people to pay for those services, but still note that you're gonna have to have a safety net for those people that can't afford it, because then it's just gonna widen the gap between the haves and the have-nots, healthcare access and no healthcare access.
Okay. And then thank you for that. I just had one more question just about compliance. Do you feel that with the pandemic, pre-COVID versus post-COVID, that patients or people are more compliant now with virtual appointments and with access to care than they were pre-COVID, or do you think it's the opposite?
No, they're not. I mean, we reach out to people. We tell people you can come to the office. We make an appointment for you. We ask these questions, where they have fever. And we told you about that. Well, they say no. That doesn't really mean a lot, but these are the questions that, CDC has recommended, and we still do it. But if you look at, they can do telemedicine. So we do telehealth as well. What happens is that people will tell you, I mean, you can't see them, you can't touch them, you can't listen to their lungs. If they have pain, urinary, so you don't know if they have rebound tenderness. You can't really fully evaluate them, but on the surface, You can just talk to them, get some of the information. I mean, a lot of times people quick to show me, they'd take off the clothes and show me stuff like, okay, way too much information on them. But but you want to see it. You say you got a rash. Well, let me see the rash. So show me the rash. Show me that, So, so telemedicine helps with that in some aspects, but you can't treat everything via telemedicine. And then if you look, and we do audits, and say, how many telemedicine have we seen during this month? How many are repeaters? And then you say, so you tell them, listen, if it gets worse or it doesn't get better, you need to come in the office. We will make sure you're protected. You have to wear your mask. We're all protected. We have our gowns, our masks, our shields, everything on, and we'll get you in and get you out. So a lot of times you can't do a lot of that on telemedicine.
Right.
So some you can. I mean, it has come full force, and I don't think it's going away. I think that when it comes to mental health, I think it can be beneficial. Mm-hmm. I think it can be beneficial, but I think eventually you have to see that person as well. I think there has to be some face-to-face.
Right. Thank you very much.
Mm-hmm.
So, Jeff Seidel put a question in the chat box about corporate leadership salaries. I'm guessing that you're talking about healthcare, Jeff. You can unmute and correct me if I'm wrong. He said they're through the roof. How should and can society be looking at this issue?
Thanks, Shannon. Just to clarify, I'm talking about corporate healthcare leadership salaries. I mean, we have CEOs close by, they're making in excess of $1 million a year. And that those salaries just commensurately go up the larger the organization. And how do we strike that balance? That's a challenge. It's a question we're not going to fix in the next 20 minutes, but
no, no, you talk about, it's a possibility of a redistribution of funds. It might be, but people are, when people have that money, it's not easy to yank it out of their hand. And they feel that, as the corporate leader, that they should be paid for that expertise and that leadership. But everybody else is, that's actually making the company go, they should also be compensated. So I think it should be a redistribution, not taking so much money from the corporate, but redistributing so that everyone has a piece of the pie, that the people that are actually keeping the pie warm. Because once those people roll out, if they go, then that corporate person doesn't have anything. They're dependent on, it's a win-win situation. They're dependent on the people that work with them and for them. So I think they have to redistribute those funds and make people help people get paid accordingly.
Sure, and the other challenge is that then it becomes a bidding war for that executive, that C-suite member.
Right.
Hopkins says, well, I'll give you 1.5 million, and University of Maryland says, oh, they're worth 1.8 million, and UPMC says, nah, I'm going 2 million, and they're going, I love it.
They're gone. 2 million wins. 2 million wins. But hospitals are losing money too.
Absolutely.
They're losing money. They're really losing lots of money. So that has to change. And I think they're looking at it. I know at Maryland, some of the other places that I'm in Hopkins, and you're looking at how do we redistribute some of these funds so that people are paid accordingly. And because if you see a lot of the people that are not seeking healthcare are working for these huge corporations that are getting a lot of this money, and they have health insurance, but they're flying under the radar. And it's a lot of social norms there too. So there's a lot that has to be dealt with. Redistribution of funds is one of them, and just to look at how it's paid out and how people are, how the pay structure is designed. It has to change. I agree.
Yeah. Thank you.
Okay, we have another question that's related to COVID-19 reimbursements. The participant said that she heard some healthcare companies refuse to reimburse for telehealth and virtual appointments that didn't pertain to COVID-19 health issues back in March and April. If this is true, are there holes in health insurance for virtual appointments, and what does this do to patients and providers?
Well, I think what this person is talking about, Cigna refused to pay. You see all these telehealth that you saw. Cigna didn't pay for those telehealth. It wasn't in Maryland, it was another state. And they're being sued because of that. But, you know, because you're in the middle of a pandemic, you tell providers that, yes, we will cover you. They send out something every 3 months. They send out, well, actually 2 months. They send out a grid about, you know, what's covered and what's not. They will continue covering telehealth until December 31st. And then some of them come out recently and said they'll continue to January 30th. And, you know, every month they reposition. So you have to literally be on it to be checking. But going back in time to when it first started and people went to telehealth and were told that it was covered, a lot of the insurances are doing what they normally do, try to figure out a way not to pay. That's the reality of it. You know, we want to see the chart first. We want, you know, so first you don't pay and say, send us we want a copy of the chart. We want to review the chart to determine if it was needed. And then we'll pay if we think it was needed. Well, the person thought it was needed when they called in or when they came in. The person thought it was, and the provider thought it was needed because they actually treated them. So then you have another set of eyes that this is what that's happening. It's very interesting. Healthcare is, which is why a lot of providers have left. You know, you could only fight so much. And if you're not making any money, and then you have the COVID and you have to close your office and you have to buy all the PPE to just stay open, and then they don't want to pay you, people just sit, hands up, all done. But so that's where we are. So yeah, so what's the alternative? Well, yeah, you can go to the companies or the healthcare facilities and go to the insurance commissioner and appeal that. If they can't come to to terms with the insurance company themselves, they can go to the insurance commissioner and appeal that. We have done that in the past. We hate to do it, but sometimes you have to go that route, and there you go. And usually it's in your favor.
Okay, thank you. So at one point during your presentation, you had a slide of two puzzles, and one was from the inside out, and one you did the border first, which, by the way, is the only way to do a puzzle as far as I'm concerned. But at the end of that slide, you said, either way, you have to start, which I thought was really, really powerful. Can you tell us how we as a community could start that, and how legislators and medical providers can work together to make that happen? Well, first we have to know that we all exist. You know, sometimes we stay in our own bubbles and we say, well, this is my medical bubble, my mental health bubble, my social health bubble, but you have to bring all of these together and sit and talk and acknowledge that there are issues that cross all of the lines, and discuss those things, and then work together to figure out a way to figure out a way to make it work, and just start. Pick one thing and start with that, and then it just sort of goes forward. Mm-hmm. But we have to talk to each other. We have to acknowledge that this is what's happening. I met with some psychiatrists and psychologists in Howard County a couple of years ago, just to talk about, and it was by chance because I met
a patient she was a patient, is a psychiatrist. And I said, oh, we're just talking. And then I went to a meeting that she invited me to, and it was very enlightening to find out what some of the issues are in the psychiatry and psychology community, as well as we're seeing some of the same things in urgent care and primary care. So, and just to look at a way to tackle those things. And it's just a matter of reaching out and talking to each other and making a plan and just starting from there.
Great. Another question, have you seen an increase in behavioral health needs in your own practice during the pandemic? And if so, are there particular diagnoses or trends that you're seeing?
Seeing a lot of clinical depression, a lot of anxiety and panic attacks, a lot of, we see people, they come in with chest pain, they can shortness of breath. And of course we say, oh my God, it must be COVID. Well, actually, you do the whole workup, you do the chest x-ray, you do all that. And no, it's more so an underlying depression. They're just, it's very difficult for them to deal with being away from their family in most cases, not having visitation, isolation, and in some cases, job loss, or members of their family have a job loss. So what impacts one part of the family affects others. So yeah, we are seeing quite a bit of that,
Okay, have another question. Are community health workers an option to reduce costs as well as help with prevention?
Are community health workers
an option to help reduce healthcare costs as well as help with prevention?
Absolutely. There is absolutely. Because community health workers actually get into the community. They are intertwined. I mean, they're embedded in most cases. So it helps, but you have to make sure that the community, that they understand the community in which they are working and able to talk. So if you have a representative and someone who can talk with the community, I think that's a good idea. Yeah, and it'll help to decrease costs as well. I think over time, not initially, but over time. So you talk about what we're seeing in the healthcare community, period. We're seeing a lot of depression, anxiety. What I didn't touch on is that you're seeing a lot of depression and anxiety within healthcare providers themselves. Mm-hmm. The fear of maybe transmitting it home to their families, not being able to see their families, isolating themselves when they go to work every day. And the fear exists, and it's real. I mean, we've had providers commit suicide. We've had people depression and needing medication. We've had it's real. We've had people just say, I cannot do this, and leave. So it's real, even in the healthcare community. We have the whole, you guys are heroes. You say, well, how much of a hero can we be, and how long can we be it?
Okay, we have a really long question from Victoria. Do you want to unmute yourself, Victoria, and say the question, or would you like me to do that?
I can unmute. I guess I'm coming from the place of frequent changes in insurance companies. People they change jobs or lose a job, and then a lot of, this is not true of all clinics, but I certainly worked at a clinic for a while that didn't take much insurance, and it was medical assistance only. So if somebody did get a job, then they'd have to change providers, or as a private practitioner now, there's no way to keep track of all the different changes with each insurance company. So I have to limit who I see. I mean, what companies I agree with, but in terms of, I try to continue continuity of care is an issue. for a lot of people.
Yeah.
And so I'm just wondering if the conversation about a single payer program is still on the table. It seems like it would ease the burden on providers, and that would make access easier. It's not just about easing the burden on providers, but also making it less, continuity of care for clients, so that they can stick with their providers and not have to.
Right, I agree, because you see a lot of people falling through the cracks simply because of that. Because they don't have what insurance they had, their provider doesn't take, or they get a different job and they get a different insurance, their provider doesn't take, so they have to seek out another provider, and that can be just disturbing. And I think a single payer model would work, but it's so much politics involved in that. And what we do is we credential with all insurances, including medical assistance, everything else, just to make sure that people don't fall through. But we get a lot of that. We say, I need to follow with the primary care. We'll help you with the medication. We'll do all this. But they can't, they have to then find primary care.
Right. I mean, the more people have to change, the less likely they are to continue with anyone. There's no.
Exactly. So they just give up.
Right.
They give up. You see somebody 3 months ago, you give them, I'm going to give you 2 months because I'm just going to take you 2 months to see a primary care, if you get one. And then they come back in the 3rd month, they need another prescription refill for their medication because they still don't have one. And insurance and companies are closing. And primary care, some of them are closing, and they're changing insurance. So people are falling through the cracks every day. So yeah, I think that a single payer would work. But tell that to Blue Cross, Cigna, United. I don't know. It's too much money involved for them to go to single payer. So that would be a major fight. But I think it's possible. I really do. Just like Medicare.
Right.
Nobody wanted Medicare. And now everybody wants it.
Yeah, Medicare is more efficient than most insurance companies now.
Absolutely.
I was disappointed in what's happened with medical assistance in the state. That was quite a mess. But I also have a comment I'll make about employee assistance programs, which I think is a beautiful idea, but there's a middleman that makes money, and then there has to be a transition for services so soon that many, many people fall through the cracks, including our healthcare providers who right now so much need competent providers. So it's a puzzle to me why we don't just make sure that everybody has what they need. Workers, not workers, just. I'll stop dominating the conversation.
No, I agree. No, I agree with you wholeheartedly.
So there was a follow-up question about our healthcare heroes and how are we supporting them?
How are we supporting them?
Yes.
Well, you have to split shifts, rotate them out so that they have some time to not just rest physically, but mentally rest. We've changed our protocol as far as how many days you work. Usually we have a three 12-hour shifts and a week, and that's it. But we found that during COVID period, it's 12 hours can be a bit much dealing with that all day. So we bring in a second provider and to help and then ease some of that. Interesting enough, the providers like that whole 312. They don't want to come in there 5 days a week. So they're like, well, you can bring in someone, I can take a break and then then, you know, and then I can go back to work. So we're trying that, you know, to get around it, because I think it can be a bit much. I still practice, you know, I practice medicine as well. So, and I know by, you know, 10 hours, it's like, seriously, is it over yet? But, but you do, you know, you push forward, and it can be draining. Healthcare period can be draining, because you're taking on everybody else's burdens, not just their burden. You are constantly, and trying to find a way through it to help them feel better, to help, and so so if you're not careful, you can push yourself to the edge. So you have to step back. So give them time to step back. And, you know, we have lunches, we bring in food, we have food delivered actually to them. You say Mondays are crazy, so we feed them, we give them snacks, you know, we try to make people feel comfortable and at a little bit at ease as much as you can, all the while screaming, keep your mask on, keep your shield on, keep your gloves on. So to make sure that you're okay.
Great. And one last question that we have here. You mentioned earlier in your presentation that prevention is cheaper, which I think that most of us can accept. But how in the healthcare arena can you prove that you prevented something? Because it didn't happen. So what kind of data do you have to support your prevention
Well, if
efforts?
you look at the number, if you take the data from the prevention aspect, how many people did you do blood pressure screenings on and identified the number of people with hypertension early on? How many people did you do evaluations on to determine if they have any underlying heart disease or kidney disease, or you find it early enough to prevent it from progressing? So you do have the data, you can utilize it, but it's not really, nobody's coming in to be screened for anything. You know, so if you're not screening them and you're not catching it early enough, preventing the untoward outcomes, then you don't have that data. I have an MPH from Hopkins, and I did, you know, there's a lot of studies always at Hopkins. And so if you look at the data, if you look at APHA and all of the studies that have been done, it does exist, but the bottom line is that there's not much screening going on. Most people come to the provider when they're sick. So it's like a sick only state, as opposed to, let me get evaluated, get a full evaluation and just see if I'm okay, even though I feel fine. But you're not rewarded for that. There's no drive for that at this point. But if you caught it early enough to prevent the untoward effects, then you could say, listen, we prevented this, this, and this because we caught these things, and these number of people increase in preventive health to show that there is an impact on the other end. Look at the decrease in heart disease, look at the decrease in hypertension, look at the decrease in people on dialysis. But within communities, looking at each communities, you can look at that data and then expand it across America. So it can happen. I'm a public health person. I mean, you know, that's my life. But I live for that.
If this pandemic has done nothing else, it has definitely shown how critically important our public health system is.
Yes, absolutely.
They are definitely the superheroes of the day here. So even though we're scheduled to go to 9:30, I don't have any more questions. So I would like to extend my warmest thank yous to you, Dr. Apollon, for doing this. It's been very enlightening. I'd also like to thank Aubrey and Rebecca, the MHA staffers who were the masterminds behind this event. Our MHA board members who have joined today, and other MHA staff, and especially our legislators who took time out of their busy days to hear about this critical issue. So hopefully, like Rebecca said at the very beginning, we'll be able to join again in person for our legislative breakfast next year in the fall of 2021. Who knows what opportunities lie before us in the next year. So thank you all and have a great rest of your day.
Thank you very much. Have a good day. Bye-bye.
Thank you.
Bye-bye.
Thank you.
Thank you.